Good evening, everybody. Welcome to this meeting of the Health and Adult Social Care Overview and Scrutiny Committee. My name is Councillor Patrick Canavan, Chair for the meeting. I'm just going to ask Louise, as the Democratic Services Officer, if she would be kind enough to read the housekeeping notice, please.
Thank you, Chair. Please note that this meeting is being recorded by the Council for live broadcast and will be published on the Council website for a minimum of 6 months. The meeting may also be recorded or streamed for live or subsequent broadcast by members of the public, although ultimate discretion in this matter lies with the Chair. For those in the room, please note that if the fire alarm sounds, please exit the building by way of the nearest available signed fire exit route and make your way to the assembly points in the front car park of this building. Finally, please ensure background noise is kept to a minimum. Mobile phones and other devices are turned off and switched to silent for the duration of the meeting. For those in the room, this includes turning off your microphones and turning down the volume on your laptops completely. Thank you. We've received apologies from Councillor Joe Salmon and Councillor Dwayne Farr.
Thank you. And any substitute members?
There are no substitutes this evening, Chair.
Could I do the usual request for people to indicate any declarations of interest, please? Councillor Allen.
Just my usual declaration that I have a contract with Dorset NHS. Oh, what's the name? What's the name of the hospital? University Hospital Dorset. There you go. It's been a long day. Sorry.
Thank you. Right, we're going to move on then to item 4, which is just confirmation of the minutes of the last meeting. So can I just confirm that everybody is content to accept those minutes held on the 19th of May as an accurate record? Everyone happy with that? Thank you very much indeed. I'm going to take the action sheet in a minute, but I just wanted to tell myself off for not thanking Councillor Dedman for her service as Vice Chair at the last meeting, which was a huge oversight on my part. So this is a very belated thank you for your service as Vice Chair, and I'm sorry that I overlooked it last time.
I'll just switch on and say thank you very much, Chairman. It was a pleasure.
Action sheet. So this is just a list of the actions, and again, unless there are any particular issues anybody wants to raise, are we just content to accept that? Thank you very much indeed. Public issues. Do we have any public issues?
There are no public issues, Chair.
Okay, now I'm going to seek your cooperation in rejuggling the agenda slightly. I did have a bright idea that it might be a good idea to take the work plan first, give us a little bit more time to look at the work plan in a little bit more detail than we have in the past. But I'm going to leave it till later on the agenda only because Lindsay, our overview and scrutiny specialist, isn't ready yet. So I'm wanting to give a bit of time in order that she can join us. So I'm just going to play it by ear, if that's okay with you, to leave it until a point on the agenda when Lindsay is available. So that then, if everybody's happy with that, what I will then do is to move on to item 7 on the agenda, which is the Adult Social Care Fulfilled Lives Transformation Programme update. And we have Betty Butlin, Director of Adult Social Care, and Tim Branson with us. So I'm going to hand over to you, please. Thank you.
Yes, so thank you, Chair. I'm going to hand over to Tim, who is going to share a presentation, which is a summary of the detailed paper that you've had circulated in the briefing notes for this committee. So thank you.
Thank you, Betty, and evening members. So thanks for inviting us back to provide you with a further update on the programme. You'll obviously have seen the paper, so just by way of a brief summary, the Fulfilled Lives programme was developed following an intensive 3-month discovery and analytics phase in early 2024, which identified significant risks to our future ability to meet our statutory duties in the face of growing demographic and economic pressures. So last year, Cabinet and full council agreed the transformation business case, which was approved with an in-principle funding of £2.9 million spread over 3 years, although it's a 4-year programme in total, with 1.79 million released for year one. We then, I think, presented a timeline earlier at the beginning of this year, where we just started to move into the programme delivery phase, which started in January. All the 4 projects within the programme are now active, and we've got a project board for each of those projects, which then in turn reports through to the Fulfilled Lives Programme Board. As Cabinet had requested, committee members have had opportunities to kind of regularly scrutinise progress of the programme. I think we had a session in November, and then two committee appearances in January and March, and obviously this is our 3rd one today. We did have some initial recruitment challenges, but I'm pleased to say we've kind of passed through those now. All of those have been resolved. So as I said, all the 4 projects are fully operational now. Now, the findings from that 3-month sprint and the rationale for the business case, that hasn't really changed, but this slide just provides some additional context around the indication, I suppose, really, of local demand growth modelling that we can expect to see over the next sort of 15 years. So that's really, I think, reinforcing that doing nothing isn't an option. And we can see that there's a predicted increase of nearly 9,000 over 65s just in the next 5 years. And as I will show later, we've had new requests for support that have continued to increase. And in fact, our statutory return for 2023-24 showed an 18% increase in demand among our under 65s and a 7% increase in the over 65 population. So our current predictive modelling suggests that increase in demand will continue over the next sort of 5, 10 and 15 years, particularly in the over 65s, as is shown here. And that means obviously we're likely to see sustained budget pressures. So we clearly need to do all we can to mitigate those increasing demand costs. And I think the measures that we're taking now through the Fulfilled Lives programme will protect us against that even higher cost growth. The Fulfilled Lives programme is, as you know, very closely aligned to our vision and our strategy, and that directly contributes to our strategic delivery plan. And the programme also shares and supports the ambitions outlined in the recently announced NHS 10-year plan, with that emphasis on integrated neighbourhood health, the shift from treatment to prevention, and the switch from analogue to digital. And you'll be familiar with the 4 component projects, so I won't dwell on these other than just to acknowledge that it is a really complex programme with many moving and interdependent parts. I'll mention in a minute a change that we're making to our first response function, which has identified around 40 essential system and process changes just to ensure successful implementation of just that one change. So it just goes to show how complex this is. This is just a reminder, really, of the overall timeline of the programme, and obviously sort of showing where we are here in the red dotted line at the moment. And going forwards, we'll obviously want to schedule in some further overview and scrutiny sessions to ensure that ongoing scrutiny. So in terms of the programme deliverables, this slide really just sort of summarises 6 of the key areas across the 4 projects. The Adult Social Care Medium Term Financial Plan for 25-26 assumes a 961,000 Fulfilled Lives transformation savings, and that's reflected in the Adult Social Care budget for the current financial year. But I think also evidence from our 3-month sprint shows that we can reasonably expect the achievement of several other benefits, such as better outcomes for residents and their families, which is what we're here for in the first place, improved staff morale and more successful recruitment, and all being well, a positive CQC inspection outcome as well. So I'm just going to walk through the four projects just with a sort of summary of the progress. I'm sure this presentation will be circulated subsequently as well. But I think the key points just to sort of highlight on the How We Work project. We were, and the two sort of key areas of this are the three conversations approach and our first response. I think now that we've kind of got some real progress in terms of the three conversations rollout, we expect, I think in the paper it says probably by the end of December. I think we can more realistically say that we'll expect all teams to have adopted three conversations by October. There'll still be a period, I think, of sort of embedding and consolidation, but I think it's fair to say that that's where we'll be by the end of October. We have also undertaken a trial recently of undertaking more of that initial conversations at the contact centre, and that has shown that we can definitely resolve a broader range of inquiry types. We can certainly reduce the number of people waiting for a Care Act assessment within our long-term conditions locality teams, and we're definitely seeing that we're removing those inconsistencies that we had in terms of our practice, which were kind of hangovers from sort of legacy council days, really. And probably most importantly, we're actually able to respond to people more quickly. So we're now proceeding to implement an expanded contact centre sort of function that will be rebranded to be called the Adult Social Care Hub, and that will reflect its kind of broader remit. And actually, this is just a quick diagram of what the hub operating that sort of first response model will look like. So on the far left, we've got our kind of broader population with steps that we're taking to enhance our sort of digital offer and our connections to our community and voluntary sector, so that ideally people can actually find solutions to some of their problems without even needing to sort of contact us in the first place. But then secondly, if a conversation with adult social care is necessary, then the hub in the centre here has three sort of components now. We'll have our contact officers who respond very much to the first point of contact, whether that's by telephone or email. We have outreach officers who can actually undertake visits to people in their homes where that's appropriate. And our intake care managers have a similar sort of function, but they can just sort of take things that little bit, that step further. And they have support from some administrative colleagues under that sort of case support heading. And then on the far right, we've got our long-term conditions team. So the idea really is that we manage to resolve as much as we can within the hub, so that our long-term conditions teams can really focus on the long-term work that they need to do. And that means that we can reduce the number of people who are waiting for a service from our locality team. So the short-term support project, we know from the analysis that we did with the Local Government Association last year that we need to rebalance our spend on long and short-term support, with an increase in short-term support and a reduction in our long-term spend. And one of the key areas for this within this project is establishing a dedicated reablement service for people living in their own homes that will ensure they get the benefit of short-term support to prevent or delay the need for long-term services. Currently, the majority of our reablement capacity is directed rightly towards hospital discharge pathways, but we're keen to make sure that we've then got a dedicated community model that means we're not always fighting for the same resource. And this project is closely connected to our first response and three conversations work, and is a real key enabler for the three conversations. Our self-directed support project, so this is progressing well. The individual service funds pilot has now entered phase 2 with a trial of our treasury management software, and we're continuing to co-produce this model with care providers and service users. And as I will show you in a moment, the trusted reviewer program is showing positive outcomes for people seeking more meaningful activities during the day. And the CME, the Community Micro Enterprise Development, is progressing well as well. We've got 2 CMEs that have now been fully accredited and they're operational. And I think we have around a further 10 CMEs in the pipeline that will be coming on stream over the next few months. And then lastly, the support at home project. So this is really around re-procuring our domiciliary care framework. The research phase for this project is complete now, and colleagues are working on the care and support at home strategy, which is nearing completion, and that will be presented to our senior leadership team in August. And then from there, the service specification will be drafted, and the procurement of that new provider framework will begin. So that's where we are with that one. And I just thought, as I know a question I think had arisen previously, I thought it might just be helpful to provide a little bit of a diagram just to show the relationship between the Fulfilled Lives programme and the Future Care programme. So a key aim of our Fulfilled Lives programme is to intervene early to prevent people needing to attend hospital, whereas Future Care focuses more on avoiding admission once somebody's arrived at the emergency department, and then reducing the lengths of stay for those people who do actually need to be admitted, so they can be discharged as soon as possible once they've completed their treatment. But I think the principal difference really is, in terms of Future Care, is there is obviously a pathway out, which includes home-based intermediate care, whereas our intermediate reablement offer is really more focused on keeping people at home without even needing to attend the hospital. And in terms of sort of discharge from hospital, our 3 conversations approach and our support at home project, and obviously self-directed support, all of those we really contribute towards making sure that when people do leave hospital, that they're actually getting the right person-centered support that they need. And then briefly a update on sort of performance. So we've developed a suite of performance metrics now, which we've arranged into a series of themes, which are shown here. I'll briefly take you through each one in a second, and sort of provide cross-references to examples that are covered in the paper that you've had. As we progress further, I think we certainly remain open-minded to developing additional performance measures to evidence the quality and effectiveness of our transformation. So the personal outcome achievement rate is our first theme. This is a key measure, really, I think, because we want residents who face challenges due to a health condition or a disability to have the same opportunity as anyone else leading as fulfilled as life as possible. So this measures, the percentage of individuals who report achieving the outcomes that they identified during assessment or support planning. And again, I'll just sort of cross-reference some examples that are in the paper in terms of how we've been achieving that to date. Reduction in long-term care packages, this is a really important one. The conversion rate of new requests for support to traditionally commissioned long-term services is a real critical measure. Our shift towards more short-term preventative support will be a key enabler again, and similarly as will our 3 conversations model. And where we've started to be able to measure the conversion rate between the number of new contacts that we get for support and those contacts that then actually convert to long-term services, what this slide is basically showing is that when we looked at a period between July 23 and January 24, we had 7,600 new requests for support. Compared the same period, July to January 24 to 25, those new requests had increased by 6.6% to 8,100. But at the same time, the number of those requests that resulted in long-term support fell. So our conversion rate fell from 11.2 to 8.2%. So that basically means that some of the steps like that we're taking with sort of 3 conversations and making sure that people are connected more to other community assets that can actually support them without the need for long-term services is actually starting to sort of bear fruit. And this just really shows the difference. If we hadn't been able to reduce that conversion rate, the red line at the top would show where we would be now, and the blue line at the bottom is showing where the actual contacts that required long-term support ended up. Now, I do just have to say there is a little bit of a caution on those last three, that sort of pink area, because that's data where people might still be in the process of completing their journey through adult social care. So we might still be midway through conducting an assessment with them and understanding what their needs are. Theme 3, this is all around the sort of timeliness and quality of assessments, and as I said earlier, much of what we're doing now is really aimed at making sure that we provide a much more timely response to people, and we expect the expansion of the Adult Social Care Hub, as I described earlier, that will further improve that speed of response for people contacting us. Community asset utilisation is again a really important thing. It's important to stress, I think, that community asset utilisation shouldn't have the effect of adding burden to family or unpaid carers. So it's really important that we don't confuse community assets with unpaid carers. So we will monitor that through our carer-related sort of performance metrics. But community asset utilisation is a key element of our strengths-based and relational practice, particularly at Conversation 1, and that will support our work to create integrated neighbourhood teams as well. And we actually held an engagement event in April, which some of you, I think, probably attended, with our voluntary sector partners, and that was in support of the development of our prevention strategy. And there was a real positive and sort of really positive support for and enthusiasm for the approach that we're taking. And finally, theme 5, I think it's important that we don't underestimate the scale of change that we're looking at here. The practice and from a practice and a cultural perspective, I guess, really, we're undoing decades of practice where we responded to people by establishing needs that were kind of with a service first. And now we're really thinking about community connection and making sure that people are actually able to sort of live a fulfilled life without sort of drawing on formal services necessarily. So our focus now is much more about sort of listening intently and not being service led in the way that we support people that we used to do. And then, yeah, before I stop really for questions, I just wanted to finish by sharing the voices of some people who have early experience of the benefits that our Fulfilled Lives programme brings. I just need to check though that I have enabled sound on this, so I'm just going to. Sorry, am I not speaking loud enough? Sorry. I'm just going to need to reshare this with the sound on so you can hear it.
The project has actually been incredible, and my future has become more of a success, obviously learning new skills and enjoying obviously trips out, catching the bus by myself. It's helping me to get ready for a promising future.
I love it. There's lots of things to do. So we go on walks out, or we go on day trips. We do woodwork, karaoke, singing, and it's very good to mix with different people of our ages. Lovely, because it shows that we can be grown up away from somewhere else to come to somewhere new. So you get a new environment and know new things.
I like doing woodwork just now. We're making Bug Hotel. We're doing a bit. I've done a bit sawing and screwing. Difficult first. I don't like changing, but when I got into it with my friends from Pottston Connect, I'm okay. But I found it hard changing over my days.
Very good. It's given me a lot more confidence and everything. more self-confidence away from the day centre. So I come on that lovely morgue bus, get on the bus, because I seem to know every morgue driver now. they keep telling me, oh, hello, Tony, I haven't seen you for a long time, where have you been?
I found Spirit was really exciting. I like it when they were doing the dancing. Songs we dance recently is like musical things, like Dream Girls. My favourite time there is where we did all round country music.
Absolutely amazing. Just the best thing that's ever happened. The way Emma and Ash and Richard treat all of the clients, they are grown up and they are all equal. They treat them as if they have no disability. And I love the fact that they give them the jobs to do. They're cooking, they're making their own drinks, the discussions they're having about, you know, mental health, relationships, all things like that.
Okay, and I'll open up for questions. Thank you.
Thank you very much indeed. Betty, did you want to add anything at this point?
Other than just to say that the paper that we've shared with you just now is also going to go to Cabinet on Wednesday, where we will be asking for the second tranche of the funding to be released so that the programme, the Transformation Lives programme, can continue. When we originally went to Cabinet, after we'd completed the initial diagnostic of the 3-month sprint, if you like, we were asking for just under, the programme was asking for just under 3 million out of transformation. So we have had so far 1.7, and we will be going back, because the programme's over a period of time and the longevity of it will need that further investment to build on the really positive results that we're beginning to see now, but we will need that to be able to finish the programme and then embed and sustain all of that going forward. And of course, the end of the programme will then bring returns financially that will come out of adult social care for the longer term, because we'll have embedded everything and changed all of the stuff that we need to do. But I think it's questions, really. I haven't really got anything else to add at this stage. Thank you, Chair.
Thank you very much. As Betty mentioned, there are a couple of recommendations in the paper, and I'm going to suggest a third one shortly. But if we just seek questions at this point, so I just got one. That slide that you showed, where it clarified the relationship between the Fulfilled Lives programme and the Future Care programme, was really helpful, actually. Just in terms of how the new arrangements are going to work, if you have somebody who has been in hospital, has come out of hospital, is receiving a package of additional support care, you know, whatever that looks like, it's probably a really stupid question, but where then does the Future Lives, the Future Care bit stop and the Fulfilled Lives bit start? If you look in a situation where somebody has got an underlying condition and there is a risk of them having, because of that condition, having to be readmitted to hospital, I'm just wondering how that interface works, if that makes any sense.
Do you want to? You go.
I think that's a really interesting question, and one that we can answer or shed some further light on. If you look at the Future Care programme, which you've also had a paper on, you remember that Dylan, who's programme director, came and presented alongside myself not too long ago. The Future Care programme is an ambitious programme around urgent and emergency care, and at this stage is initially focused on discharge and really helping with the discharge flow and discharge process. So if somebody is in hospital, let's say somebody is in one of our university Dorset Hospital. You've got me.
Sorry.
confused.
So sorry.
Can I go there?
I've forgotten as well.
So whenever we have someone who's there, then the transfer of care hub, which is a multidisciplinary team of professionals such as social workers, OTs, therapists, you know, our care, our brokers, all of that kind of MDT approach. They would pick up those individuals that need support at the point of discharge, and they would make sure that they offer. This is what the transfer care work stream in the future care program is doing. They are building up to making sure that everybody who leaves goes on the right pathway. So if it's somebody who can return home, then they should return home instead of going into a temporary alternative for that. So that's what the transfer of care under future care will do. And then what will happen, our social workers will be involved in that. They know that we're working very much to our fulfilled lives and our strengths-based approaches. So what they will do is they will be part of that joined up approach and that decision making for that individual. But once somebody is transferring into adult care for short-term or long-term provision, we will make sure that they go through the route of the Fulfilled Lives program, which is all about short-term intervention. So there is a connect to future care at the point of discharge, especially for new people who haven't been known to adult social care, because they will be discharged under the umbrella of future care, but we will work hand in glove at taking that person into adult social care if they need to. If they don't need to, then we will help to make sure that they don't by default end up somewhere that they don't need to. And where we will hope to get is when somebody is admitted into a hospital and they're being very well supported within adult social care and through some of the offers within our commissioning colleagues and through some of the work that we've been doing, we would like to see that they don't get handed over to anyone at the point of their discharge as well. So all of those things are in the next phases of what we're doing. So there is that real connection at the point of discharge, but we are constantly involved in that with future care. And as you know, I'm SRO on the Pathway 1 discharge stream for future care, as well as the SRO for our Fulfilled Lives programme. So those connections are very, very tangible. And we do have to make sure that there's no duplication. And I've always said that about the two programmes. That's the one fundamental thing that we need to always be super conscious of, that we don't make duplication, because it wouldn't be right for that individual. Don't know if you wanted to add anything, Tim.
No, I think we have got a really good established contact now with future care programs. So myself and one of the program leads from that program, we could keep in touch quite regularly, so to make sure that we're not double counting in terms of any sort of benefit tracking, that kind of thing. So I think Betty's covered it really in terms of making sure then that we're not sort of falling over each other in terms of when we are supporting somebody, that is there's that clear delineation really.
Thank you, Councillor Allen.
I have 3 questions if I can remember them. My first question is, you talk about the conversations that are having at the hub, or what will be the hub, and that's potentially that quite a lot of queries are being dealt with at that point rather than it becoming more formal. So I'd quite like to just hear perhaps some examples of those conversations. And my second question is, you highlighted the fact that reablement is definitely always going to be a pressure when someone's coming out of hospital. But I think I'd like to hear more about what your plans are around reablement of people that are just struggling in the community before they actually go into hospital, because in a way, that's almost more of a drain on our resources. And then my what was my third question? I've forgotten. I'll give you 2 and I'll think what the third one is. Thank you.
I think Tim can do the first one and maybe Sina can do the second one on reablement, Chair, if that's okay.
Yeah, I can certainly contribute to the second one as well. I think in terms of examples from the hub, probably don't bring some to the top of my head at the moment, but I think that the sort of typical thing that we tend to find is people who have got an issue that we are able to sort of connect them to think, they'll come up with an issue that we can say, okay, well, there's these things that are actually available in your local community that you may or not have known about. Have a look at those. We can do a follow-up call with those people, maybe in a couple of weeks' time, say, that suggestion that we made, was that helpful to you? If not, then we can look at something else. So it's really just a way of making sure that those needs don't escalate any further than they need to. Sometimes it's about making some referrals, maybe to primary care or whatever. So obviously, if it's a very much a health thing, then we'd be clear about that, and we can make sure that people are connected in the right way to the right support, really.
I think just to add into that, Councillor Allen, I think it's also about making sure that we have the right resources at our hub, so that people don't need to be transferred into our long-term teams. Because usually when you get into a long-term team, they kind of stay there by definition for a long time, and it's much better if we're able to pick people up and deal with their presenting needs or presenting issues that they might come to us about, and actually follow it through at the first point of contact, and not have loads of handoffs, and making every contact with that person count. So what we're doing is looking at having the front end of our services really geared up to be able to deal with all of that, and actually help people at the initial time that they come into us, rather than have all of our resources at the back end, where people will just stay much longer, and sometimes will go into the back end inappropriately. And what we want people to do is to live their lives, and not necessarily just have service after service after service. So it's about really equipping the front end of our hub to do all of this stuff. And we are getting there. I've just come from downstairs with lots of the staff who are in the hub, and we're making sure that we've got safeguarding experts in there at the minute with them, really triaging the safeguarding, rather than it all going over into the longer term safeguarding area, where then you just can become longer by the time you get to that. So we're finding really good ways of using the programme to be able to bolster up the short-term end, so that the people get what they need. And as Tim said, it's not easy, and it's a real culture change. And you all know it takes a long time to embed a complete big change in how you work, and the culture and the staff with that. So it is about bringing people with us, and using the data to really inform how things are progressing, and what areas we might need to go back and relook at. But so far, the programme is really showing its value, and really showing that in the longer term, it will be more beneficial for the individuals who come through needing our support. Yeah, thank you.
Thank you. Councillor, did you remember your other question?
I did, and it's interesting you say that. So my third question was, you highlighted some of the definite benefits of people not getting into long-term care, which I think is excellent, which sounds like you're just giving people what they really need, rather than sort of, I think we tend to sort of take people and think we know what they need, and all of a sudden they're like in the middle of everything, and actually all they wanted was probably just signposting. So that's excellent. You mentioned about timelines, but you didn't tell us whether that is actually improving. So I suppose my question is, you're saying that you're having the right conversations early on, and you're trying to front load that, but is that shortening the time from somebody presenting to them actually getting the support? Sorry, that was the third question. Thank you.
Yeah, no, absolutely, because we're having that conversation right at that earliest point, and because people aren't needing to wait for us to have those kind of conversations, we're actually connecting people a lot quicker. So it actually sort of staves off that need for anything more comprehensive to happen.
And do you have any figures to share with us about that at some point? So, I mean, it makes total sense that this is quicker. Totally makes sense, but it would be really interesting to see the sort of actual numbers from the individuals. Thank you.
we can certainly bring that. I think perhaps when we come next time, we can certainly bring that that data for you. Yeah, no problem at all.
Sina.
Thank you, Chair. Yeah, if I can come back to your question too about reablement. So yes, we've over the last 10 months we've been reviewing the reablement services that we've got. And like Tim alluded to, a lot of it was most of the capacity that we had was absolutely focused on hospital discharges. So we've been working with our current providers around increasing their capacity, and they've done that by looking at their processes and their systems over the last 10 months. But that hasn't given us the extra capacity we need for the community. So we're looking at, so our plan is to go out to commission a pilot over the next 12 months for a solely reablement community service. So it will be just about avoidance and admission avoidance, and just for Betty's long-term the locality teams to access that service. It will not be targeted at the hospital because they already have that capacity.
I just think that's really important, because I think it's very, very easy with the pressures that everyone's under that it's reactionary, and reactionary is always expensive. So if you can get ahead of it and do the prevention stuff, and it's often where people are just starting to stumble, if you can catch them then and like prop them back up, hopefully they won't need to go into hospital, they won't need long-term care, they won't lose their capacity to be able to function. So I do think that's really, really important for your cost benefits longer term. So I would really like to hear about that once it comes through, because that would be really useful. Thank you, Chair.
Thank you very much indeed. Councillor Northover.
Thank you. I was just reading through, and I haven't been on this committee for very long, but I was on it a few years ago, and then I was on it maybe 15 years ago, and I can't help but feel that I've seen this before, you know, that we would have person-centred approach with things, and, you know, just very similar themes. And I just wonder, do we implement these things and then they get forgotten, or do we or is it just where we reorganize and things go by the wayside? Do we just need to be having this as a rolling project almost all of the time? Because I kind of look at this and think, wow, why weren't we doing all those things? Because they're blindingly obvious, and we've known about, you know, as long as I've been involved in things, you know, 20 years, this is what we were meant to be doing anyway, isn't it? So
so like you, I've been around a while and have seen things come and go, I guess is what I would say. What I haven't seen though, and I genuinely mean this, is the complete programme coming together where one bit feeds into the other and is dependent on the other for each of them to be successful. So what I've seen before is a start in one area, but maybe not have done a diagnostic in the true way that we did it under the sprint. And that's not to ditch what happened at that time. That was probably the right thing at that time, because demand would have been less, and there may not have been the same pressure on national allocation for adult social care and all of that kind of stuff. But I think we're in a different world now. I think the landscape's completely different. I think people want to be empowered to be in control of their health and their care needs, and they want to know everything about that. And that's right and that's proper. But I think for me, if I was to say what's different about this programme, I would say it is because we followed it through from one to the end, rather than starting something and then realising, oh, we need more reablement. Oh, we didn't factor that in. So therefore, the individual's gone on to long-term care. And then they've become used to long-term care and not wanted to come off it, or felt they couldn't come off it. Where had we been able to give them, that's just an illustration. You know, you could use lots of examples. We didn't have the same technology that we're having within this programme. We haven't had the same scope within that. We have not had the same market flexibility and feasibility with all of the providers. You know, we're going to different, the way Sina explained, we're going to different providers. We're going to providers that are small as well, that are large, and we're looking at how we can flex all of that kind of stuff. and we're looking at how we work. We have not changed, as far as I can recall, we have not changed our front door to the level that we're converting it into a hub. We have always bolstered our back end to the extreme, and now we're looking to at least balance that or reverse that, whatever is the most appropriate. So I would agree, and I hear what you're saying loud and clear, but hopefully I've told you what's different, completely different, and come and have a look. Come and see for yourself. Come and have a look. I'm going out tomorrow to see something, because there's nothing like seeing it to actually be able to tangibly say, well, I know that's different. And the days that you refer to, I was probably a social worker doing some of that stuff at that time. So I guess that's what I would say, but I'm going to see if Chair's okay, if Tim might want to add.
Thanks, Betty. Yeah, I think the only other thing I would say is I think one of the fundamental differences is that three conversations approach. So, and a bit like Councillor Allen was just saying, we sometimes don't recognise or remember that people are experts in their own lives, and actually for us to go in and claim to be the experts and then I suppose really dish out services to them because that's what we do as experts. That is, I think, is a key difference. That we're going in, we're starting with the person first and foremost, and actually really listening to what's important to them, and actually focusing on that rather than asking lots of other questions that we probably routinely do that don't bear any. So I don't have any bearing on their particular sort of circumstances, and that can very often end up in people being sort of railroaded into services when they needn't have been.
Thank you. I'll take a final question from Councillor Moriarty. Oh, more questions. But need to move on, surely. Councillor Moriarty.
I'll be quick. One is a comment and the other is a question, if that's okay. First of all, it's really good that you've made very explicit that unpaid carers aren't under any more pressure, because that is a hugely important thing. In terms of, you also said that there was a lot of positive feedback. I'm just wondering, is there any negative feedback and any trends within that might indicate that there's something that needs to be jiggled a little bit more?
So from people that we've worked with, I don't think we've really had any negative feedback. I mean, most of it has, as I say, been overwhelmingly positive, particularly around the sort of speed of response. And I think the other key one that comes up quite a lot is people really feeling like we've listened to them properly this time, compared to previous occasions when they may have had dealings with us. So that's been really, really sort of encouraging. From a staff point of view, so we get feedback from people, we get feedback from staff as well. In fact, I've had a report this morning from our Preparing for Adulthood team, a 6-month. They've been doing this for 6 months now, so sort of getting some feedback on a range of different sort of measures that we look at with them. And again, I would say probably, and again, recognising that this is a big cultural shift, so it sounds simple, but it's not easy. And I think probably it was about sort of 75% of people were saying, yeah, this is really a better way of working. We can see the difference that it's making to the people that we work with, and we're definitely getting that sort of feedback from them that this is a better way of working. The other 25%, I think they're not saying it's worse. I think it's just taking them a little bit longer to kind of get into the swing of things, really.
Okay, we'll take Louise and then Councillor Denman, and then I think we need to move back to the recommendations, if that's okay. Louise.
Thank you, Chair. I was just wondering about the time it takes to get calls answered for people who are ringing through to the hub. I'm just asking because we happened to have a call just last week from a woman who was 94 and she left hospital, but she needed some care at home. And I think we hear a lot about how there's all this joined up work, but actually we do get calls from people who've kind of slipped through the net somehow, being discharged without that support. She was trying to get through. She'd spent 3/4 of an hour on the phone and hadn't managed to get through. And I think she'd been kind of passed around, so she was a bit confused. She'd been sent to a GP who couldn't help. She'd been sent to somebody else who couldn't help, which is often when people get through to us, is because they've passed through a few places. So just wondering that sort of time of what it takes to get through to the hub, and whether there's a way for people to leave a message to get a call back or something like that, that would have been helpful in this situation.
So call wait times can vary. I haven't got the numbers off the top of my head, but I seem to recall our average kind of wait time is around 5 to 7 minutes, which isn't bad really, given the volumes of calls that we get. That said, because some conversations may take longer than others, that might inevitably mean that just depends if it's somebody's calling at a time when there's a lot of demand on those calls and they're all happen to be quite lengthy calls. That can lead to a slightly longer wait than the average, I guess. We don't currently actually have a voicemail sort of facility on there. We do offer options in terms of people being able to kind of contact us in other ways, other than voicemail, and that is something that we are sort of looking at. But what we found when we did try that once before was that very often we're then spending a lot of time trying to get hold of the person, ringing back, and they're not there, and then so again that sort of ties up our practitioner time. So it's a balance that we've got to try and strike, really.
Councillor Dedden.
Yes, thank you, Chairman. I just want to come back on one comment that was made by Tim with my geriatric empirical experience. I would really challenge that people are experts in their own lives. I know exactly what you mean, but a lot of people think they can do a lot of things that they actually can't. And I think that needs to be accepted. I'm not suggesting that we featherbed everybody, far from it. And I totally agree. I think this report is brilliant. I think the work you're doing is brilliant. But I think we need to make sure that some people say, well, it's like when you go to the doctor and the doctor says, how are you? And you say, I'm fine. No, you're not, because you're at the doctor. It's that really that I just wanted to point out. But the thing I really wanted to mention, Chairman, was it's in the report here about these community micro enterprises, which you need to expand the range of. And I wondered how that was going. And also, can't we think of another name for them? Because it's such a mouthful, isn't it? There must be something else. So thank you.
Yes, I don't know where that name actually originated from, but you're right, it is quite a mouthful. So as I say, we've got we're partnered with an organisation called Community Catalysts. They work sort of nationally, and they've recruited a local representative who is part of that particular element of the project, and her role is to basically stimulate the local market for small providers to offer the sorts of support that people may be more interested in doing compared to your more traditional kind of day service type of opportunity. So an example, I think one of the ones that's just gone live is offering almost like allotment type experiences. So people who like gardening can actually go to this allotment and actually spend their time, working there and doing what they enjoy most. And that's more meaningful activity for that person than sitting in a day centre, for instance. So, and I think there's about another 10 of these. So this is I think it's a 2-year overall sort of programme. So the person that we've got that's doing that, I mean, they're reaching out on social media, so they're doing lots of ways of actually sort of engaging with the local sort of provider market. As I say, there's about another 10 in the pipeline, and we would expect that to sort of continue really beyond that period then, really.
Okay, can I move us back to the recommendations? You'll see in the paper that there are 2 recommendations which I'm kind of hoping the committee will agree to support. What I was going to suggest is that we add a third one, which I'm going to read out, which is that the Health and Adult Social Care Overview and Scrutiny Committee continues to monitor this 4-year programme, in particular around self-directed support and support at home that will enable people to stay independent and reduce the need for residential placements. So the reason for that is, as we mentioned, it is a 4-year programme. It is actually on the agenda, as we'll see when we come on to the work plan for our next meeting. But what went through my mind was we might welcome an opportunity to have another look at it in some months' time, just to see how it's going, see how much progress we've made. So that was the thinking behind that additional recommendation. I'm just hoping that there is Councillor looking very sceptical.
Chairman, I was just not terribly happy about the bit about reducing the need for residential placements. I know I was a nursing home owner, I'm sorry about that, but I don't think that's necessary. I think the whole thing is a whole big thing without putting that bit in, but otherwise, yes, fine.
I can take that bit out if people think that end bit out and just people stay independent, full stop. Betty.
So that's I have no issue with either of what you said, but I'm not surprised that Councillor Limon picked that bit up and welcome that. But I think it's residential in the wider context as well. So there are people going into residential care that are going on because we have the wrong pathway offer at the minute, and it might be. But and I know that you're referring to the longer term. But if we capture and really do what this program says it's going to do, we will get to people earlier. So we should be able to delay. Might not be that we completely prevent them, but we might be able to delay them going in. So therefore the overall number over that period of that time will be less, if that makes sense.
Sorry, Chairman, my view was, Betty, sorry, can I talk through you to Betty? I've got no quibble with that, as you know, but what I'm quibbling with is actually putting it in a recommendation which is just not got the explanation that you've just given us. It'll just go to Cabinet. The outside world will look at it and think, oh dear, cutting costs. It was that bit that I'm not keen on.
Councillor Owen.
Yeah, I think it's too. I agree with you. It's a bit of a too blunt a thing to actually say this is our end goal, because it's not. Your end goal is getting the people the appropriate care at the appropriate time and enabling them to hopefully get to that point a bit later because you've helped them to cope better. And the long term outcome should be that you have less need for residential care, or it may be that you don't, because actually your needs growing, so you may actually not reduce what you have to do. It might just be that it slows it down. So I think it's I don't think it's about residential care. It's about the appropriate care for the right person at the right time. So I agree, Chair. Thank you.
So we should just take those last few words out with that. Yeah. Okay. Thank you. Everybody content with that? Well, I'll report that to Cabinet on Wednesday. Thank you for that. We have Lindsay that has joined us, and thank you for waiting, Lindsay. I'm just hoping that you're still with us and we're able to deal with the work plan. Good evening, Lindsay.
Evening, yeah, I'm here.
Thank you. Okay, let's just going to have a quick kind of canter through the work program, just to try and take stock of where we are. So in terms of the next meeting in September, you will see that there are some items that we have already kind of scheduled for then. The adult social care prevention strategy is something new. We've very just briefly touched on it earlier, and something which I know Zena and the team have been working on. So we did have a presentation on that recently, as was referred to at the Hamworthy Club. So that's going to be on the agenda for September, just so that we can let the committee know what's happening there. But the other issues really are the Directorate Budget Awareness Programme. Now that's obviously quite a big plug. That's obviously quite a big bit of work. So what I would just ask the committee to do is, between now and sometime approaching that meeting, to have a think about what data the committee would like to ask Betty to produce when we come to look at that particular issue. It is going to be something which obviously it's going to come under some scrutiny given the financial pressures of the council. But if colleagues could think about what what data they would like, that would be really helpful. You will recall, obviously, that we did previously look at the booked beds. I constantly have problems with that. And I've no doubt we'll probably want to ask how we're doing with that in terms of the budget. So that's something else. But also in terms of Tricuro, this will be the first time for a while that we've had Tricuro come to talk to us about their business plan. So again, any thoughts about data would be really helpful, and to think also about the the expectations, I guess, that we might be wanting to place on Tricuro in terms of reablement, and questions around that sort of issues. So just that, I'm just flagging that up ready for you to think about in terms of additional data, and if you could let us know what you'd like us to try and, or like officers to try and produce, that would be really helpful. So that's that is September. It's quite busy, but we can do this. So that, and then we've got in December, as you can see, the integrated neighbourhood teams. That's been kicking around for a while, but we thought it might be helpful to get a bit of an update on where we are. The world of the NHS is changing quite rapidly, so it might be an opportune time to take stock of where we are. And then we've got some our formal reports that we need to look at, which is the Safeguarding Adults Board Annual Report and the Social Care Complaints and Quality Assurance Annual Report. So we need to look at those. We're still looking at whether or not we can deal with the end of life services, but again, it's a bit of a changing scene. So we will do it if we can, but it's a bit dependent on how officers and colleagues elsewhere feel about whether or not they're going to be ready to be able to come to us to say something about that. So that's the plan. Just in terms of the work, the kind of, if we just cast our mind back to the priorities that we decided for ourselves some time ago, hopefully, certainly by the end of this year, we will have completed all of those items that we kind of set ourselves as priorities. And then we have a fairly long list of other issues which have been raised at various times. We're still outstanding a report from our colleagues at UHD on the kind of aspects of their kind of transformation program. We've looked at the clinical services stuff, but there is a wider piece of work going on about the transformation of that work, and we've asked Richard Rano from UHD to come, and we will try and fit that in at some point. Just I wanted to say there are a couple of items on there which are have been raised by colleagues in terms of things that we might want to look at. You will recall, it's not on this list, but you recall at the last meeting, I raised the fact that Councillor Salmon had asked about the possibility of us looking at the sub-co proposal within the hospitals, and we did have the separate presentation on that, and we have circulated the slides that Richard Renaud presented to us on that. What we kind of left him with a list of things to send us after the end of that meeting. What he's kindly sent us now is a very long and detailed report of the whole idea, really, that went to the trust boards. Very detailed report, and what I was intending to do with your agreement is to circulate that document just so that you can see that it reaffirms what Richard was telling us at the meeting in terms of the reassurances that he was giving us then. So that's what I'm intending to do. We're not going to be in a position anytime soon, I don't think, to have a look at the impact on personal independent payments, because it's going to be dependent on what happens. It is a wish to do it, but I think we just need to be clearer as to what's happening when all of this stuff eventually gets through the House of Commons. And then on the Lifeway stuff, which was a particular issue that was raised with a care provider, what I asked colleagues in adult social care if they would do is, I don't think it's very helpful for us to look at that issue in isolation. So at the end of this meeting, Zena is going to helpfully give us a presentation about adult social care commissioning, because I just think it's important to understand the background to the way in which commissioning works, because you can't always rule out the incidents like Lifeways. You can do what you can in terms of inspection and monitoring, but sometimes stuff happens, and I just felt it would be helpful, and Tina's very kindly agreed to give us a presentation on that. So that's my 6 pennyworth for all of that. Lindsay, what have I missed and what have I done wrong?
I don't think you missed anything, Chair. I think you've covered everything I had written down. Unless Louise had anything else she wanted to raise, that's all from me.
No, I think you've covered everything.
It's never a good sign, is it? Any questions on? Oh, Councillor Allen.
The transformation of UHD, and again, I declare that I have an interest because I have worked there and still have contract with them. But I'm very aware that other trusts around the country are starting to cut staff, and recruitment is being squeezed, and there are some hospitals in the country where they've actually had recruitment freezes. And I am concerned on whether or not UHD are actually managing to recruit correctly and retain. And I also, and this is away from UHD, but I have a colleague who works at Bournemouth University and informed me recently that all the new recently qualified nurses coming out of the university are not getting jobs. So we've invested in these nurses, and the staff of the hospital have worked very hard to help train them. And I was told that they were taken into a room and basically told, even some of them had pre-arranged jobs. No, you're not going to get any jobs because there's just not the money around to recruit new nurses, and some of them are actually going home to work in their mum's hotels because they can't get jobs. I also heard something else recently about a newly qualified, I think it was either occupational therapist or a physiotherapist, can't remember exactly, but the exact same information that there's just no jobs for them, and that from this position with this hat on, but also just my experience of working in the hospital is bonkers, because there's just the staff on their knees, desperately need for more staff, pressures on overtime, pressures on bank, pressures on using outside sourced nursing. And I genuinely do think that there may be an issue coming down the line around recruitment and retention within UHD that I don't know that people have eyes on. So I think they might be working very hard to do transformation, but are they really getting the right staff in, and are they looking after the staff they've got, and are they retaining them? So some of this is my experience of working there. So I'm happy to admit that, but some of this is just stuff I'm hearing wider, and I am concerned about it. So I do think that actually the knock-on effect to us as a council and as a community from potentially, they need to be honest with us. If we're getting to the point of recruitment freezes, if they're getting to the point of not replacing staff when they leave, they're getting to the point of, it's again, it's the day job, and I've got to be a bit careful, but I can tell you that it's very, very hard to recruit into that hospital. It takes so long to get anything through, and I just think that maybe we need to have eyes on that. Thank you.
No, thank you very much for raising that. I think, well, we would have had a presentation sooner, I think, from Richard about where UHD is at, and we're really just waiting to kind of fit that into the programme. Sorry, Betty.
No, I think that's absolutely right. And I think just on some of the points that Councillor Allen has raised, particularly around the nursing element, as well as, you know, all of the posts are incredibly important. It may be something that from today's, you know, today's conversation committee, that we may want to ask the chief nurse at UHD to come back maybe with so I'm very happy to pick that up with them. If the committee want to draft a question, then I'm very happy to follow that through. Thank you, Chair.
I'm sure we can do that, Councillor. Lindsay, is there anything else that we need to touch on, do you think?
The only thing that I thought might be worth raising was I know that members have been asking about having specific data requests covered in reports, and so just thinking about the best mechanism to make sure that your reports do cover everything you'd hope that they do and the timescales around that. And I wanted to suggest to the committee that when you come to a meeting like today, if you're able to look ahead to the following meeting on the work plan and think about what your specific data and information requests might be, and perhaps with some email communication before the meeting between you as a committee, then if you could confirm those within a committee meeting ready for the following one, I think that would be a good lead-in time to enable officers to respond to what those might be. So I just wanted to suggest that as a sort of system, you might want to consider starting to work in that way.
Yes, thank you, Lindsay. It's a bit of a reminder, I think, for us all to do a bit of homework to ensure that we, you know, that we're on top of that and to request that data. So thank you for the reminder. We'll certainly try and fit that in. So we will try and work on an appropriate question to see if we can extract some information from UHD. But it's probably also worth just mentioning that we have, or I have, badgered our Director of Public Health about the issues to do with the reorganisation in the health service, and about whether or not it might be a good idea to get either the Chief Executive or the Deputy Chief Executive of the ICB to come talk to us about change. But the trouble is, it is moving so quickly. It's a bit difficult at the minute, but I haven't forgotten about it, and I don't think Robbie's allowed to forget about it. But it's happening, stuff's happening really quickly, but I do have it in the back of my mind to try and fit something in if we can, to just to get our brains in gear as to the scale of this is quite phenomenal, really. So for us just to understand it would be helpful, I think. So that's still on my list of things to do. Anything else on the work plan? Let's see.
So just on that last point, Chair, I think that is really, really important. And I think it's all about the timing, and it's about what can be shared when it's worked up. Some things may not yet have been worked up. We're still navigating, you know, as a Dorset-wide system around some of this. So I think it's really helpful, and I'm absolutely sure the chair or the chief exec or the deputy from NHS Dorset would be more than happy to come at the time that they're able to share you know, their plans around some of what is very sensitive, but is also really important to the committee. So I think we just need to gauge that, and we have already had preliminary conversations just off the cuff in passing around, you know, the committee may wish to ask, because I know you've had conversations with several officers just kind of building up to that. So I think it's really important, but when the time is right, and we will absolutely do that. Thank you.
Yes, thank you very much indeed. We'll do that. Can we move on then, colleagues? Let's move on to the CQC update. So I'm going to ask Betty if you could give us a bit of an update on that, please.
Yes, thank you, Chair. So Sina is going to kindly share the slide. This is verbal update, but I've done it in the form of some slides for you guys, for the committee. As you know, CQC are doing assurance processes on councils in their adult social care. areas, and they have. I'm going to just get Stina to pass the slides through if we can, and I can talk you through what I've done. Okay, so just wanted to give you a bit of information just on the current status. If we can go to the next slide. Thank you. Now these figures have changed slightly as of today. So this shows it is a moving feast. But the current status are that there was initially 5 pilot sites that undertook pilots in regards to the assurance process that is carried out by CQC. There were 45 completed reports on the CQC website. There are now, I believe, 96 notified in progress. I changed it slightly this afternoon, and 11 that are waiting notification. We are one of those 11. We have not been notified, so we are way down to the wire, nearly, as you would put it. Our colleagues in Dorset Council have told me today they heard today. So I've been waiting with bated breath today. I may still hear, today's not over, but I would be surprised at such late hour to hear. But that said, who knows? So they heard today. They heard around 10 o'clock. I've been told. So we are one of 11. So I've shared with you on this, if you could see it okay, the up and coming dates of notification. So CQC have been notifying us really on a 4 weekly basis. That's when they've been sending out the notifications. So today, the 14th of July, and I keep putting a bet on, I've got a pound on with one of my colleagues over there that it was going to be today, so I've lost a pound so far. And the 4th of August is the next time, and then the 1st of September, and then that's it. Everybody will have heard. We've run out of runway. There are no more times to be told. So it is imminent. Cannot stress enough how imminent it is. And I've just shown you some of the outcomes. So you know that it's a rating of 4, inadequate, requires improvement, good, and outstanding. 1 outstanding, and I go into a little bit more detail on those 4 areas further through my slides. So I'll come on to the next. So basically the process that happened is the notification from CQC. Once that process starts, they email the Director of Adult Social Care. That's who they email to notify them of the inspection. Assurance process, I shouldn't really call it an inspection, whether it feels like that or not. It is an assurance process. So they will notify me, and then the ball begins to start rolling. And within 3 weeks, you submit what is referred to as information requests. So they will give a big long list and detail of what they want from us. And we know the things and the areas of that. So we have been preparing for that a lot. But you have to keep regularly updating that because some of the things fall out of the timeline. But we are where we are. And CQC review that, and then they start to engage with organisations such as Louise's. They'll start to contact providers within the voluntary and community sector and other stakeholders to inform about on-site visits. And then they will tell us what the date of the visits that they're going to actually be here in this building with us and what that might look like, and the interviews and the kind of detail of all of that. We will give them a number of cases or individuals' journeys, I guess is the better way to describe it, which will all be anonymous. We have to provide them with around 50. And then from that 50, they will take a range of those. Now they are clear about that they want to see people from all of adult social care areas. So people with mental health, people with alcohol and drugs, are discharged, people being discharged, etc. All of the whole range. And they will select roughly between 6, but they'll have some in reserves, and they will go into all of those people's journeys and look and talk and look at all of the work that's happened and the outcomes and how it was for them. Now it can take a while from them to notify you to be here. It really varies, to be honest. It's how long is a piece of string? Some people have had them, you know, within a couple of weeks. Some have been within several months. And then once the inspection's done, they will give high level feedback roughly after 2 weeks. And that feedback is given, and then they will do a draft report. And that draft report we can then go back on for accuracy and for other detail within that. So we can do that. You can do factual accuracy checking, etc. And in the final report received, roughly the timeline for that is 2 weeks from when the local authority receives the final report to publication. Then that will go out to publication. Now, this is all in principle, and they aim to work to this. But some people have waited longer for their reports to be published online and all that kind of stuff. So, you know, we were just talking about that earlier today. So next slide, please, Sina. Thank you. So some of the stuff that we're really working on that is our strengths is, you know, really working with our frontline practitioners who are proud to deliver and are enabled to be creative, working towards the best outcomes, a bit with the stuff that Tim had said about fulfilled lives. We're fully integrated and well established in areas, and you know, a lot of you know this, within our learning disability and mental health, we have integrated teams, and we oversee a lot of those integrated teams. Our work is often refers to under prevention as well, with our voluntary sector partners in the range of preventative measures that we have. And we're investing more funding in the development of our care technology, and that links in with our fulfilled lives. And we have our care tech strategy. So we'll share all of this as well as our strengths based, not wanting to repeat a lot of what Tim has already shared with us. And our relationships with lots of partners are very, very positive. And as of March, so I will update this again to make sure that it's right up to the current day. 98% of BCP areas, domiciliary care providers, were rated good or outstanding. So that's positive. And our relationships with the independent provider markets have been really good. And we have initiatives such as Pride to Care, well-established boards such as our Learning Disability Partnership Board, and our sort of engagement team that focus very much around people that are self-neglecting and or hoarding and transitioning from safeguarding areas where there's been safeguarding concerns. And of course, our Preparing for Adulthood, that is the transition between children's and adult teams. So we kind of get in there whenever somebody's the age 14, 15. And some of you may have, you know, experience of us doing this. And our homeless intervention team, drug and alcohol, and substance misuse. So lots of really, really good strengths. It's really important that we showcase our strengths and that we get our practitioners to be able to do that. And with the strengths come areas that you're working on, because not everything will always be a strength. And I've just, so next slide, I've just listed some of those areas. You know, we want to further embed our audits and our practice standards and our quality assurance. We want to get that even better than what it is. We want to reduce the number of people that wait for service provisions, and some of that is all around the front door. And we want to improve our offer to unpaid carers. I know one of you mentioned that earlier. And really, really co-produce all of our strategies, in particular our carers. And we want also to have much more flexible ways of giving people control and support over what way they want to get their needs met. Those that are able to do that, of course, and deliver inequalities and diversity and inclusion, really strategic approach within adult services. And then just really further on our data as well. You talked about data earlier in this. Just really have those systems that are so strong that data is telling us where we need to go and where our gaps are and what we could achieve. And we've much improved in that area, but we could improve even more. Thank you, Sina. So just going on to our approach, that's what we'll share, but how we're making sure we're doing all that. And then just the next slide into that is around our adult social care strategy that we brought here. Do you remember I said we had thousands of hits on the website? And that's our vision. support people to achieve a fulfilled life in the way that they choose, in the place where they want to, where they feel safe. And it's about putting people and carers and families first, living in the place called home and developing how we work. So just moving on to the next one around that. So in adult social care, we have a dedicated group of staff who have always worked in adult social care who we've taken to really focus on this piece of work. And they meet weekly. We have done all communications. We communicate a lot with our adult social care workforce. We've got CQC champions. We're analysing information from everywhere. We're not proud in adult care. We'll take the learning from anybody. If there's anything to be taken, we will take it and we will ask. And I think one of the really good things for us that we've really kind of got no shame about is we'll take any offer from any national pot that allows somebody else to come in and have a look at what we're doing. I was just agreeing something around learning disabilities and autism on Friday with Partners for Care and Health. So having others come in and really have a good look at you. You'll know that we did our peer review with the LGA, and you'll know that we did our bespoke safeguarding. So our preparation is as much as we can prepare, really, to some extent. We've looked everywhere. We've looked internally, other departments, and wider afield. So next slide, please. Sina, I think we're nearly coming to the end of them. So our information return prep is we've got a tracker. We're analysing where we're at because we know what information CQC will ask us for because they're very open about that and it's a lot of detail. And then we're looking to see if there's any gap analysis where we can identify where evidence should be further developed. Our heads of service in each of their areas are really the owners of the evidence within their areas. And we have a CQC planning group, and we have our senior leadership team in adult social care that review all of our final documents that will go what we will send. And our self-assessment that gives you've had our self-assessment come here, a really good live overview of everything that's going on within adult care. That's live, and we will always have that now, irrespective of CQC. It's a really good thing to have. And then just moving on to the next slide. So I've told you about the 50 plus CQC champions from adult social care. They meet. We've got point of contact for staff across adult care. We've got focus groups. We've got distribution of key messages. We've had webinars. We maintain our knowledge and relevant skills. And we our practice in relation to adult social care. And tomorrow, we have one of our colleagues nationally coming down to meet with 100 or so of our staff who have already gone through this process and who are really tuned into everybody else. And we've already had some sessions already happen with others within adult social care. And then just moving on. So there, I've just kind of touched on that. So the next, the kind of next dates I've told you about, so I'm not going to rehearse that. We haven't heard so far today, and that's just some further other things that we've been doing, which I think I've covered anyway. Just onto the next one, please, Sina. So the presentations, and some of you, someone like Patrick, who's the chair of this group, will most likely be involved in the CQC assurance process. They may well ask for that involvement, and of course our portfolio holder, Councillor Brown. So we will have a senior leadership team, which will be, the adult social care leaders, people like the leader, like other various members, and some other officers from within the council. We know who that will be, and they're very specific to some degree around who they want. So that'll be a 3-hour session where we will deliver and showcase and point out the areas. And it's about also being really clear just around how much you know yourself, because not everything's great and not everything's wonderful. And of course, there's areas for further improvement, but it's about actually knowing that and what's your plan to get from A to B. and the opportunity just to provide that wider context. And I've kind of just cited there, you know, who may be involved in some of that as well. So just moving on, please, Tina. And that's it. So I've kind of taken you through that in a really quick way, but I will absolutely keep everybody informed. And as I say, some of you may be involved in it anyway. And if committee wanted to have our self-assessment, which is the document that kind of encapsulates everything, I'm really happy if members would want that, to have that circulated, and you could read that, you know, kind of periodically, because it's quite a chunky document with quite a lot in it, but a really helpful document that'll give you all you need about adult care. Thank you, Chair.
Thank you very much indeed. Any questions, Councillor Dedden?
I just want to comment. I feel amazed at the depth of all this. As a former provider, you've got a building, they come in, they grumble all the time, and off they go again. I'm thinking, crumbs, Betty, you know, I'm glad I'm not you, but I'm sure it will be perfect.
Councillor Allen.
I think it's very good that you've outlined so many of the positive things that you've shared with us, and that you have highlighted some room for improvement. I suppose this is a difficult question, but you know, is there one or two little bits areas within that you're thinking, oh, that's a bit tight, that's going to be a difficult conversation, this is something that they may pick up on? So sorry, but you've told me all the positives. Is there any couple of negatives in there that we need to be concerned about? Thank you.
So there is absolutely room for growth, and we know what those areas of growth are, and we will be really open and transparent about those, because it's much better if we share and then give our plan. Our transformation program is one of the key things that we will showcase as a way of getting to people sooner, therefore reducing those people that maybe have to wait, that go on what is traditionally known as waiting lists. One of the areas that is an area that we know that we would rather not have, but we are doing some further work on and having some further resource allocated to that, is our reviews for those people waiting deprivation of liberty. We risk assess everybody, and we have a higher list than what we would like, but we have got a plan. We'll be really open and transparent. If I'm being totally honest, a lot of councils and adult social care are in a similar position to us in regards to that area, because it was around a change in judgment that happened around 10 years ago, and it changed the criteria around that, so your volume is much higher, but the resource hasn't kept up with the volume. And we do risk assess, and we do use a risk tool, and we are looking at any slippage of any sort in any money. That is where it's being targeted as well. So I'll be very open and honest about that. And I think if I'm being honest, one of the areas for me is just about really trying to nail the transformation program, so that it does bring that much bigger focus on short term at the front door rather than a build up at the back door. Would kind of be, but we are far from perfect. As much as I would love to be, we are far from it, but we are in such a better position this year to what we were last year. And I would say one of the areas that a year ago I would have been a lot more concerned about, that I'm not as concerned about, I guess, is what I would choose. I would never say I'm never not concerned about anything, because the world changes on day to day, is our quality and performance and assurance frameworks that we have in place to be able to monitor. And we have a board, we have an executive board that the leader comes to, our portfolio, and is chaired by the chief exec. So we've kind of really pushed that governance, that it sits in the right place. It's just about really keeping that momentum going in those areas. And of course, safeguarding is always going to be an issue that concerns that is a concern to us. I'm not saying it's a particular concern, but it's because of the nature of that area. You just don't know. I don't know who it was who said earlier, you can mitigate and mitigate, but you just don't know sometimes what's going to come. So yeah, so we're far from complacent around anything, and we just keep working to strive for the best possible outcomes. Thank you.
Thank you very much, Patty. Thank you. If that's okay, we'll move on. I think the next item on the agenda is portfolio holders update. Councillor Brown. What did I miss? Sorry, Louise, I didn't see you. Beg your pardon.
I was just going to say to Betty that if you're still checking your phone, I could let you know that I haven't heard from CQC in the last week. So.
I've got this vision of Betty checking her phone every 5 minutes. Thank you. Councillor Brown.
Thank you, Chair. You know, I looked at what I updated the committee on last time in May, and it's very much the same, really. There's the sort of ongoing, continuing work, really, around adult social care fulfilled lives programme, which you've had presented tonight. The future care work, public health. Obviously, it's carrying on. And CQC inspection preparedness. Interestingly, I also meet with the portfolio holders for adult social care across the southwest on a sort of monthly basis. We've got our next meeting on Friday, and that's always on the agenda. CQC assurance visits and who's been visited and how what their experience was, and you know, the sorts of things you need to sort of be aware of. So yeah, it's certainly across the southwest. I think we're going to be probably the last in the southwest now, aren't we, in terms of the authorities being visited. So, but yeah, we have regular sort of catch-ups and on that. So quite looking forward to it. I'm pleased it wasn't just after, was it 2 years ago we had the LGA peer review when CQC were just starting their stuff. I'm pleased it wasn't straight away then that we've had. I think we were well prepared then, but I think certainly there's much more scope to actually demonstrate the sort of positive impacts that we've been having on people's lives now. I'll just quickly run through a few other things that have been going on. Quite a lot of conversations in the last month or two about the financial outturn across the Wellbeing Directorate. There's a cabinet report on Wednesday of the financial outturn across all parts of the council. And actually, although partway through the year, there was forecast that in adult social care we'd have overspent the budget and there was lots of pressures there, but there's been an awful lot of work across the teams to manage that. And the final outturn for adult social care was an underspend of £19,000, which is not bad on a £125 million budget to come that close to delivering on, actually delivering just probably 0.001% under budget. But the various different, if you look at the cabinet report, pressures within that. So some areas were over, and then there's other sort of mitigating factors against that. But I think overall, it's a really good. I think it's a really good demonstration of the sort of work across the teams to make sure that we work within the resources that we've got available to us and still manage to deliver for people. And on the commissioning side, actually, that was £707,000 better than budgeted. So yeah, a really sort of good result, even though on a sort of difficult, pressured year. So yeah, so that's one area, and members could look at the cabinet report if they want sort of more detail on that. There's been a reference to the adult social care prevention event that was towards the end of May. I felt that was a really useful, really positive meeting, not just for adult social care staff, but some partners as well, and voluntary sector were there. And I think I made the point when I spoke at that it's already something that everybody sort of does as part of their job to an extent, that nobody sort of doesn't pay attention to the fact that, we can sort of help people with preventative measures, but it's actually been much more thoughtful and intentional about prevention, and actually sort of really sort of working across all sorts of parts of the council really to support people. So yeah, that was a really interesting event, and so we'll look forward to the sort of report coming to Cabinet and how we take that forward. There was a Care Home Open Week in June. I don't know whether members were aware of the National Care Home Open Week. Certainly I had an invite from one of the care homes in my ward that I went along to and spent an hour or two with having a nice 3-course lunch with a couple of the residents there. And it's really useful actually to visit and just speak to people and understand. It does open your eyes to how people sort of enter care services. And it sticks with me. I spoke to a number of people there, and some had been in the care home, for a few years. But there was one lady there on a sort of week's visit, paid for by her family, sort of a private arrangement because she was struggling with things. And from what I could pick up, they hadn't actually been in touch with social care. It was very much a sort of private arrangement that, she was sort of a bit homebound because of health issues, and so her son had been coping, and then decided to contact the care home. So she'd gone there and managed to, in conversation with the manager, make sure that they had then just about got signposted towards social care. But it's really interesting to know that, to us, we sort of tend to have an understanding of how social care services work, but when people are out there and actually need access to those services, it's not always obvious, and actually they're trying to do the best for their relatives, but don't know, actually I'd need to pick up the phone and speak to the council. There's lots of different routes. It's not just, oh, there's a residential care home. Actually, there's all sorts of different services that you could access before you get to that point. So yeah, it really opens your eyes, I think, speaking to people and the experiences they have in homes and how they get there and how they're getting on. So I'd recommend to any of you, if you've got major care homes in your wards, I'm sure we probably all do, to probably make contact with them, have a chat, and I'm sure they'd sort of open their doors to you and welcome a visit to sort of, and let you meet some of the residents and find out how things are going. So yeah, that was a really eye-opening, useful visit. We had the public health assurance visit at the end of June. I'm sure Rob could give much more detail, but it was I thought it was a really positive visit by the regional director of public health who visits to come and assure himself that that we are spending the public health grant the way we're required to spend it. And fortunately, we've had a letter following that up to that he is assured that we're doing what we need to do with public health. But actually, it was it's not so much an inspection visit. It was a really sort of positive, constructive visit where he was very there was a lot of collegiate working and recommending that, oh, actually, if that's an issue in the BCP area, maybe you need to speak to these people in another part of the country that have actually wrestled with that type of issue and would be able to sort of, help inform you about the way to go. There was a lot of that sort of conversation. So it was a really sort of positive collegiate working assurance visit. So not just a sort of box ticking, oh, are you doing the right things, but actually, how can we help you actually sort of progress and do things better and for the people of BCP. So yeah, that was a really useful visit. Last week we had the Learning Disability Partnership Board, and I know the committee chair attended that as well. Quite a few hours, sat down with people. There were carers, there was social care staff, people with learning disabilities, and parents and families to really sort of work through the development of their big plan, to actually focus on continually improving services. I've had a big plan that's sort of worked on particular focus areas to improve services for people with learning disabilities, and it's really reworking the big plan to sort of continue to focus on continuous improvement and co-producing a plan to actually make sure that we are serving people with learning disabilities as best as we can. On the sort of health side, we have an integrated care partnership meeting this Thursday. I'm not sure how many more meetings there will be after that, because as I think has been mentioned about the 10-year plan, and it seems to talk about the potential finishing of integrated care partnerships, and potentially, that could change responsibilities of health and wellbeing boards. So it's we'll wait and see what happens with that. But yeah, I think the 10-year plan will continue to have quite some ramifications and needs to be sort of to work through to see actually how it is going to affect how we work. But yeah, the whole sort of integrated care board and integrated care partnerships and health and wellbeing board responsibilities will be shifting over the coming months. Actually, tomorrow I've got another visit actually to our Lifeline team. I don't know if members are aware of our sort of lifeline services that people can take advantage of, and the whole sort of care technology side of things. And they've got a place in Kinson that they have social worker visits to sort of show them the sort of equipment that's available and what can be done. So I've arranged myself to have a visit to them, go and check out what I might need in 20 years' time. But yeah, just to get a real understanding of the type of services that they can offer families in this area. And other than that, really, as has been mentioned, our Social Care Fulfilled Lives report comes to Cabinet on Wednesday morning, and thank you for your input and comments on that. That'll be taken on board. And the Corporate Director for Wellbeing post is out to advert. The recruitment advert is out, so that will be progressing over the next couple of months. So we'll see what we can do there.
Thank you, David. Any questions for Councillor Brown? Councillor Dillon.
Yes, can I just say, Councillor Brown, I'm really glad you had a good experience at a care home. Give a plug for care homes, but usually lots is going on and the food is always excellent as far as I know. You should also get tea time, lots of little cakes. No, I wanted to ask, is there any news on Highcliffe Day Centre? Because I gather it's opening slightly, and I wondered if it's going to be open for what it was used for, which was a day centre.
It's not reopening as a day centre because it was a Tricuro day centre previously, wasn't it? But I know it's been partially opened and now used for the preschool, isn't it? Mudderford Wood Preschool is using part of the premises for it. But yeah, I mean, in terms of it being a day centre, that was sort of decided through the Day Opportunities programme that would not reopen. So it was then as a sort of a BCP property that's surplus to requirements was offered to other parts of the council, whether it be children's services or housing. That's always how it happens with surplus properties. Certain service units sometimes look at a building and actually say, actually, we've got a priority. We need.
I'm so sorry, David. I can hardly hear up here.
Yeah, so it's not reopening as a day centre, but it is being used for other activities. And just on the food at care homes, actually, yeah, the Magna care home that I went to, the chef was proud to tell me that it was award-winning food. She just received a national award, to which I could respond, actually, well, we're from an award-winning council because we just won the MJ award. So yeah, we're all full of awards. But yeah, it was. I suppose it was your classic three-course meal, you know, with the soup to start and a nice sort of chicken and leek pie with potatoes and vegetables and I think it was a cheesecake for dessert, something like that. So yeah, probably what you'd imagine. But yeah, it was a really nice sort of atmosphere to be able to sit down with people and just sort of chat to them about how their experiences. So.
Thank you. Okay, well, I think we've reached the end of the meeting. So I'm going to close the full meeting and thank the officers and for all the presentations that we've had. Thank you all for attending. But just a reminder that immediately after this, we're going to do a briefing separately, which won't be online. Okay, so thank you very much. I'm going to close the meeting now. Thank you.